Okay, so in this section, we're going to talk about tocolytic medications. The first thing you need to know is that all the meds that we use for tocolysis are used off-label. There are no drugs specifically developed to stop contractions, but there are a lot of drugs that we know that have either anti-adrenergic effects or that have some effect, or I'm sorry, adrenergic effects, not anti-adrenergic, that have some effects that would decrease those contractions. The second thing you need to know is that tocolytics do not decrease the rate of preterm birth. So usually, if we're giving these medications, the best that we can get is delaying birth long enough to get the patient in preterm labor to a facility that can care for a preterm infant, and long enough to administer some steroids, because steroids administered to the mother actually accelerate fetal lung maturity. So you have to understand that we're not giving these meds to actually prevent preterm birth, because they're not very effective at that. Magnesium sulfate is a med that's been given for preterm labor for a long time, and it does actually slow contractions sometimes. What they really think, and this is with all tocolytics, what they really think with all of these meds is that if they slow the contractions down, or if they stop the contractions, that patient probably wouldn't have delivered anyway. But sometimes the patient that would have delivered, we can slow them down enough to get some meds in. But mag sulfate also decreases the risk of cerebral palsy in an infant that's going to be born very preterm. And so in the earlier preterm labor patients, mag sulfate will be given primarily to prevent cerebral palsy, or to decrease the risk of cerebral palsy. So the classes of drugs that can be used as tocolytics. Tocolytic means it breaks up contraction, right? So tocolytics are things that stop contractions. Beta adrenergic agonist, terbutaline is the most common. Its trade name, or one of the trade names, is frethine, which gives you a hint as to what it was developed for. Beta adrenergic agonists have been used for asthma and for bronchodilators for a long time, but they also relax the uterus. So what are the side effects of adrenergic agonists? They're going to cause jitteriness, they're going to cause increased heart rate, increased blood pressure, unless we get the heart rate so fast that the heart doesn't have time to fill, and then they can actually decrease cardiac output and decrease blood pressure. There is some risk with these meds of pulmonary edema because of the increased heart rate. So that increased heart rate can be enough to put some patients into some congestive failure and pulmonary edema. Now, it's not uncommon, or it didn't used to be uncommon, to give terbutaline, and if that didn't work, to follow it with mag sulfate. And mag sulfate actually increases the risk of pulmonary edema as well. So if the patient has had both of those, their risk for pulmonary edema is higher. So we have to be assessing breath sounds really carefully. So either one of these meds, either beta agonist or mag, you've got to be assessing breath sounds. Another option, another class of meds that may be given for preterm contractions is calcium channel blockers. Nifedipine is the most common one. They inhibit calcium from entering the smooth muscle cells, and so they inhibit smooth muscle contraction. Think about how calcium channel blockers lower blood pressure. Okay, they cause vasodilation, right? So if calcium channel blockers lower blood pressure by vasodilation, then one of the side effects is going to be orthostatic hypotension. Something else that you need to understand, though, is that they have a really dangerous synergistic effect with mag sulfate. If we give mag sulfate and nifedipine in the same time frame, we can actually put that patient into respiratory rest. Okay, they have very similar effects, and they can work synergistically. It's also going to mean if we have a calcium channel blocker, our patients on mag sulfate and they become toxic, we can't counteract that with calcium gluconate because we're blocking the calcium channels. The half-life of nifedipine is 2 to 5 hours. So if we're waiting for it to be completely cleared before mag sulfate is given, that's like what, 25 hours at the longest. So they're very cautious when switching from one to the other, and they're going to wait at least the lower end of that 5 half-lives. They're going to wait at least like 10 hours. A lot of facilities, the policies that they can't have had any nifedipine for the last maybe 12 hours. We've got to be really cautious with changing from nifedipine to mag sulfate. We also should not give calcium channel blockers too soon after beta adrenergic agonist, because again, that's going to increase the risk of heart failure. NSAIDs. NSAIDs, you're familiar with for pain, for swelling. They block production of prostaglandins. And remember that prostaglandin, we think may be a factor in the onset of labor. So the one that's most commonly given is indomethacin. The thing you need to understand about NSAIDs, though, is that it causes the ductus arteriosus to close. In fact, sometimes in a newborn whose ductus is not closing as soon as we need it or we expect it to, they actually sometimes give indomethacin with that purpose. So if we give the mother indomethacin for very long, it can cause premature closure of the ductus arteriosus, which is going to have a really problematic effect on fetal circulation. Okay. So it can only be given for 2 to 3 days. If the ductus arteriosus closes early, then the fetus can have pulmonary hypertension. Magnesium sulfate is another tocolytic that can be used. It relaxes smooth muscle. All of the things you learned about monitoring mag sulfate for preeclampsia, it's still mag sulfate. You still have to monitor those things. You've got to monitor for respiratory depression, for central nervous system depression, muscle weakness, decreased DTRs, monitor blood pressure. If a baby is born and the mother's been on mag sulfate, then they're going to have decreased muscle tone and possibly some respiratory and central nervous system depression. So those mag babies a lot of times are born floppier and maybe a little slower to take the first breaths. Something else to know, if your patient is, and we're going to go back to the preeclampsia thing, if your patient is getting mag sulfate for preeclampsia and they're trying to induce labor because they need to get that baby delivered, it can be more difficult to get good contractions. So it's kind of like they're working against each other. So it can interfere with the induction. It's still done. It just can make that induction with Pitocin take longer. But the other piece of that is if you've had a patient with mag during labor, and that can be either for preeclampsia or for preterm labor, that patient has had mag sulfate, remember it causes muscle relaxation. After birth, we need those uterine muscles to clamp down to stop hemorrhage. So if the muscles can't clamp down effectively, that patient is at risk for postpartum hemorrhage. So there's a greater risk of postpartum hemorrhage after birth. Remember the very dangerous interaction with calcium channel blockers. Mag toxicity is considered 10 milliequivalents or greater. So 10 milliequivalents or greater is considered toxic level, but also we're assessing the patient. The patient has no DTRs. We cannot get deep tendon reflexes, respiratory rate less than 12, or if they have severe hypotension. Altered level of consciousness, they're not waking up or not as alert as we expect them to be, or extreme weakness. All of those are also signs of mag toxicity. We need to stop mag, monitor, stay with them, monitor them very closely, contact the provider. Mag assessments, we need vital signs every 15 minutes, continuous fetal monitoring, hourly INO, hourly DTRs, hourly respiratory assessment, just like with preeclampsia. The difference is, while there is still risk of fluid overload and pulmonary edema, it's lower with the preterm labor patient that doesn't have preeclampsia, because preeclampsia also has that risk. And also, we're not monitoring for those signs of impending eclampsia. So all the other MAG assessments we're still doing. Interventions, still typically, if we have that patient on mag sulfate, their total IV fluid is usually limited to 125 milliliters an hour. Some facilities have a lower limit than that, okay? But we don't want to fluid overload them because of the risk of pulmonary edema. And calcium gluconate should be immediately available. So those are the types of meds that are given to stop contractions or to try to slow down contractions. And again, they're not very effective at stopping preterm birth. If they stop the contractions completely, that person probably wasn't going to deliver. What they can do is bias a couple of days. And the reason we need that couple of days, number one, we want that patient in a facility equipped to handle a preterm baby. But number two, if we give some glucocorticoids, some corticosteroids, if we give those injections before delivery, it accelerates fetal lung maturity. So typically we give betamethasone, sometimes dexamethasone is used. They're given IM. Betamethasone is the most common. It's 12 milligrams Q 24 hours times 2 doses. So they want to give 2 doses 24 hours apart. Okay. Dexamethasone dosing is a little bit different. Don't have to remember that dosing, but you do need to remember that for betamethasone, ideally we want 2 doses 24 hours apart. Now, sometimes they will shorten that time frame. If that patient really looks like they're going to deliver, they may shorten that to 12 hours to try to get the second dose in. It's most effective if we can do 24 hours, but if the baby's already born at 24 hours, that's not going to help, right? So we try to get 2 doses 24 hours apart. I've seen them sometimes bump that second dose up. Okay, ideally, after the second dose, delivery is delayed another 24 hours. So if we can get meds to slow their contractions down enough for a 48-hour delay, we can drastically improve outcomes. One of the major side effects of the corticosteroid dose is hyperglycemia. So if your patient has gestational diabetes or pre-existing diabetes, we give the steroid shots, and they're not going to withhold them. They're concerned about fetal lung maturity, but we also are prepared to manage that hyperglycemia. It's going to run their blood sugar up. It can cause some hyperglycemia even in patients who are not diabetic. Another side effect of steroid doses is sometimes some agitation and difficulty sleeping. So if the patient is like, I don't know why I can't sleep, just reassuring them that, that may be because of the steroids can be helpful. If the contractions stop and they start back again later, if it's been more than 2 weeks since the last course, they may actually repeat the steroids. More than 2 courses are not recommended. Okay. Now, preterm birth, what are the guidelines for preterm birth? Between 24 and 32 weeks, it's recommended that mag sulfate be given for about 24 hours, and that decreases the risk of neurologic injury to the fetus. Okay. We cannot transfer a patient who is in active labor or who is unstable. So ideally, we transport that patient to a facility equipped to handle a fetus, a preterm delivery at that gestational age. So if we have a patient who's 28 weeks in preterm labor, we want them transferred to a facility that can handle a 28-week preemie. Okay. So 35 or 36 weeks, that can often be managed at our rural hospitals. Before like 34 weeks, pretty often they want to move them. They want to get them out. Okay, so it's got to be a facility that can handle that labor. So we want them transported to a tertiary care center. They have to be transported while they're stable, and we cannot have them in active labor. So that's another reason that we give those tocolytics. If we can stop them from progressing long enough to get them shipped somewhere that can handle the baby, they're better off. Outcomes are better if they're transported before delivery. Labor can progress rapidly and unexpectedly. So if you have a patient in preterm labor and you're monitoring them, don't expect that labor to progress the way full-term labor does. They can seem to not have a lot going on and then suddenly have a lot of progress. Also remember that you have a smaller fetus, so delivery doesn't require dilation to 10 centimeters. So they can rapidly, hey, I feel like something's happening. I've had that happen. I was actually years ago, typically in a labor and delivery unit, you're 1-to-1 if your patient's in active labor. You might be 1-to-2 if they're earlier. 1-to-3 should be only for patients that are stable and not expected to do anything. So I actually had 3 patients who were all preterm, all stable. We were not recording any contractions on the monitors. We're looking, not seeing any contractions. Patients are complaining. So I'm just monitoring these patients with the goal of transferring them to the antepartum unit if they continue to stay stable. So that's why I have 3. And I went to assess one of my patients for my hourly assessment. And she said, I feel something. And she had gone from no recordable contractions on the monitor and no contractions that she could feel to about to deliver within just a few minutes. She probably was having contractions, but because her uterus was smaller, she didn't feel them, and the monitor does not always pick them up. So labor can progress rapidly and unexpectedly. So if that patient's been having preterm labor, we need to watch them closely. Delivery doesn't require full dilation. The other thing is when you're monitoring that labor, we're used to, in labor and delivery, in a full-term pregnancy, we put the TOCO, the external fetal monitor, usually pretty high on the fundus. We want it closer to the top of the fundus to catch those contractions. In preterm labor, if you have it at the top of the fundus, you often are not catching the contractions. So number 1, you might try lower, but number 2, if you don't see contractions on your external monitor with preterm labor, try a couple of different spots, especially if your patient is still saying that they feel something. Try some different spots. If the baby is born in a facility that is not equipped to care for them, then you do need to be able to provide emergency care until transport arrives. Malpresentation in preterm delivery is more common. It's more common that those preterm babies are in different positions, different presentation. Breech is a lot more common. Breech delivery with a preterm infant is really not recommended at all. So unless the baby is actively delivering when you discover it, they're going to do a C-section. And that's because the body's smaller, so there's less dilation that takes place before the body starts to deliver, and there's a bigger size differential between the body and the head. So entrapment of the aftercoming head is a higher risk than with a full-term fetus. Okay, in the next section, we're going to talk about premature rupture of the membranes as another complication of labor.